Okay, all set. So we are looking at the various risk factors for cardiometabolic diseases, CMR, cardiometabolic risk factors, out of which today we are going to talk about the hypertension as the risk factor for cardiovascular disease. Okay. Now, as you know, here the systolic blood pressure, diastolic blood pressure marked here, all of you know. Diastolic blood pressure should be around 80 to 90 and systolic blood pressure maximum 139. Anything more than 140 systolic or more than 90 diastolic, 90 or equivalent diastolic is the pre-hypertension, is in between these ranges. Anything more than that is called hypertension. Most important thing is the isolated systolic hypertension. Isolated systolic hypertension, when we say, when the diastolic blood pressure is normal, but the systolic blood pressure exceeds 160. Okay, the pulse pressure is more predictive of CVD. Always look for the pulse pressure. If pulse pressure is wider, it is a greater CVD risk. 90% have isolated systolic hypertension by the age of 60. Hypertension is a strong risk factor for coronary artery disease. 90% of the hypertension usually is primary. In some other class, we will cover about the secondary hypertension. Now you see a hypertension and relative risk of stroke and myocardial infarction. You can see normotensives are the red graph, and myocardial infarction is the people, stroke is the red graph, and myocardial infarction is the yellow points there. So in normotensives, both stroke and myocardial infarction are very, very low. As you can see, they are very low here. But as the hypertension increases, we can see the risk of stroke as well as risk of myocardial infarction both go very steeply. It means the 5-year risk of stroke or myocardial infarction is very high once somebody crosses that 140 upper limit as the diastolic or 80 upper limit as the systolic. And beyond 200, the risk is very high. So this 140 is not a number just like that it was pulled out from hat, 140 and 90. These are numbers based on research where the risk steeply starts increasing. That is the cutoff point for normotension. Okay. Now you see this is a systolic blood pressure is more dangerous or diastolic blood pressure. This question, many of the people, you people think that diastolic blood pressure is dangerous. It is not like that. If you see the pink bars, you can see there 160 plus systolic, they have the highest risk. When the diastolic is less than 70, even if the diastolic is less than 70, if the systolic is more than 160, that means the pulse pressure is very wide. They are at a higher risk. Compared to another person whose diastolic blood pressure is more than 100, the risk is only 21. Okay, whereas here the risk is 81. Both are important. Diastolic and systolic both are elevated, it is 48, but systolic alone is 61 when the diastolic pressure is normal. This underscores very clearly that systolic hypertension should not be ignored. Don't say you are old, so it will be 70, 180, not like that. Anybody more than 140, it should be brought to treatment. So as you can see here, the next slide. Here, Framingham heart study, CV mortality, men and women. You see people who are white color are normotensives, yellow are the hypertensives. Normotensives, the age adjusted ratio per 1000 is 29 risk ratio, whereas in 65 in case of hypertensives, like that 14 and 35 in case of women. The relative risk also 2.2 in men and 2.5 in women. What does that mean? A person without hypertension, if he is having a risk of 1, a person with hypertension, the risk is 2.2 times or 2.5 times, depending on the gender. Women and hypertension is even more dangerous. Now, treatment for systolic for hypertension and CV mortality. So, if somebody is on treatment, somebody is on good control versus on treatment without control, stroke, CHD, vascular deaths, all of them are much higher. I mean, the overall BP difference between these two groups is 15 to 60 minimum, 34%, 19%, and 23%. Reduction in the risk is the odds ratio. That means if I treat the hypertension to goal, the outcomes are better. there is a reduction in the risk compared to when the difference is when the goal blood pressure is not achieved. Not only hypertension is dangerous, untreated hypertension is more dangerous, and treatment of hypertension confers a positive benefit for the patient. With this data, we can say hypertension is a modifiable risk factor. The big six are there. Before that, we have seen the non-modifiable risk factors like age, gender, ethnicity, premature coronary artery disease history, and then personality, phenotype B. We have seen those things. These are the non-modifiable risk factors. Here are the modifiable risk factors. We covered diabetes, dyslipidemia, and hypertension. Now let us look at smoking as a risk factor. See, the smoking is a universal devil. Everywhere you can see this is measured in terms of pack years. What are pack years? Number of packets smoked per day multiplied by the number of years. Suppose somebody is smoking half a packet, 0.5, 10 years he is smoking. It is 0.5 into 10, it becomes 5. That is, somebody is smoking 5 packets per day into 15 years. 5 into 15 is 75. This is the, yeah. Yes, one packet is 20 cigarettes, standard package. So, this is again, it depends upon filtered, non-filtered, what type of brand he smokes, all those variations are there. Having said that, every time you see a smoking, you don't just write patient is a smoker. You mention the pack years, in terms of pack years, you always mention in the care sheet. So the deadliest devil is with us. What is that? The smoking. The smoking is a universal hazard for everyone. Luckily, in our country, 50% of the population, women are not smokers mostly, unless in very high society or very low society. Women in the middle rank are generally not smokers in our country. But in other countries, women smoking also is very much there. Now you see that teenage smoking is, see this man, he is smoking on one hand and his leg is being smoked. This is a very catchy picture. He thinks he is smoking, but a smoker smoking is smoking. It is not he is enjoying smoking. Smoking is enjoying him. Smoking his leg. You see that peripheral artery disease and peripheral amputation. The commonest cause of amputation of the lower limb is diabetes. Next important cause is smoking. Smoking and diabetes coupled together, sure one of the limb will go away within very short time. So this picture, I have put it in my clinic. Everyone was so astonished to see this picture and they understood. So there is a beautiful poem by Bhartrhari. He says, Bhogena bhunkta vayameva bhunkta. Says, the bhogas are the smoking, etc. They are not enjoying us. We are not enjoying the bhogas. And bhogas are enjoying us. If you eat more food, don't think you are enjoying the food. Food will enjoy you. If you smoke, you are not enjoying the smoking. Smoking will enjoy you. Bhogena bhunkta, vayameva bhunkta. Bhoga is not, you are not enjoying the bhoga. And we are being enjoyed by the bhoga, by these things. That is a beautiful, this one. Now you see the women smoking has become very much passive smoking. See that young infant and the mother's, this one, both, another lady is having one child in the womb and both of them are smoking left and right. What will happen to the womb, baby in the womb, and what will happen to the baby in the lab? All are affected. So women smoking, passive smoking in buses, public places, railway stations, hospitals. That's why they have marked no smoking zones to avoid the smoking. And teenage smokers is tender people, 15 years, 12 years, 10 years, and girls, boys, without any discrepancy. People are smoking left and right. They are thinking they are enjoying. They are not enjoying. Smoking is enjoying them. In due course, all of them will be patients of cardiovascular disease. Tell me, what harm does smoking not cause? You take textbook and find out what disease is not caused by smoking. There is no one disease. There is no one disease which is not caused by smoking. Ulcerative colitis. They say it is protective. Ulcerative colitis is such a rare disease. This statement is to say that every disease is connected one way or other. Is connected to the smoke. Honestly. Okay. Now, smoking-related cardiovascular mortality in the year 2002, you see the worldwide, industrialized countries, developing countries. So worldwide, the smoking is, total men and women. Total men and women. Wherever you see millions of adults aged more than 30 years, smoking-related CV mortality is so high in Western world. There is very much. Industrialized countries and developing countries also are not lagging behind. We will copy all bad things from the Western world, none of their good habits. Okay, this is our specialty. Tobacco smoke and metabolic syndrome in adolescents. Not exposed to smoking 1.2, exposed to smoking 5.4, and active smokers 8.7. The percent of people with the metabolic syndrome increases. ETS is environmental tobacco smoke. Environmental tobacco smoke means passive smoking, other forms of tobacco that is used, all those things will come. So active smokers, needless to say, 8.5 times more involved. So we have covered diabetes mellitus, dyslipidemia, hypertension, smoking, overweight and obesity, and physical inactivity. These are two other devils which we already have. Obesity and sedentary lifestyle, two important culprits. Physical inactivity, heart unhealthy dietary habits. These give rise to overweight and obesity. This causes insulin resistance, lipid and other metabolic abnormalities come. Metabolic syndrome sets in very soon. So now what are the cutoff points? Indians are very special. So for everybody, BMI of 25 is normal. For us, BMI of 23 itself is already pre-diabetes. 23 to 24.9, and more than 25 obesity. So we always think BMI 25. For Indians, it is not the cutoff point. Indians, the cutoff point is 23. BMI must be less than 23 because we are already having the phenotype B. We are already having a lot of diabetes in our country. And again, the waist circumference is a very important measure of central adiposity and obesity. Waist circumference for men is normal being 90 centimeters, that is 36 inches, and waist circumference for women normally is 80 centimeters or 32 inches. Now we have to find out which woman has got 32 inches waist and which man is stopping with 36 inches waist. Very difficult to find out. Everybody, the abdominal obesity is so prevalent. Central adiposity causes increase in the interleukin 6, which increases the hepatic HSCRP, which is again metabolically very active, sort of neuroamine there, interleukin 6, and that causes a lot of problems. So what are the cutoff values? BMI less than 23, waist circumference less than 90 for men centimeters, and less than 80 for women. So inch tape is the best diagnostics tool for central obesity, and all of you should look for the central obesity. Look at this man. This man is so obese, not able to get up from the chair. He is using a remote to control the remote. There is a remote on the tea table. So that is not able to go and pick it up. So he is using a remote. You see, no more leaning forward to get the remote from the coffee table means greater convenience for TV viewers. Television watching became even more comfortable and convenient this week with Sony's introduction of a new remotely controlled remote. What is this? Where are we? Where are we going? Where were our grandparents? What they were doing? What amount of physical activity they were having? We are totally, ridden to the chair. Find a seat. Go to the railway station. You'll be looking for a chair. You don't want to walk the 10 minutes before the train comes. So where is the chair? So one person gets up immediately. You start because today sitting is today's smoking. If you don't smoke, no problem. But if you sit always, it is good enough. Worse than smoking. Today's smoking is replaced. Sitting is today's smoking. Okay. So television watching, that's the remote, See, this fellow is asked to walk a dog. I have advised this man to walk a dog. What did he do? He bought a treadmill. He bought a dog. and tied the dog onto the treadmill, and the dog is walking on the treadmill. He is with his Coca-Cola and the jetty and watching the TV. Who will become better? The dog will become better. This man will not be fitting that chair anymore. After next time when we see the slide, he will be not probably in this universe. He would have left for a good abode. He would have lost his life. That is the way we are. That's the way we walk the dog. Okay. See, this man, the ape man, to become a Homo erectus sapiens took 2.5 million years to become a healthy adult. Now what happened? In 50 years, we became McDonald man, Burger King man, Pizza man, Swiggy man, Zomato man, name every damn thing. Always a TV and a recliner also, and a bottle in the hand, a drink, any type of drink, soft or hard. And then the abdominal obesity, metabolic risk, we crashed in 50 years, whatever we have gained. Okay, metabolic syndrome, hypertriglyceridemia, low HDL, elevated ApoB, small dense LDL particles, inflammatory profile, insulin resistance, hyperinsulinemia, glucose intolerance, impaired fibrinolysis, endothelial dysfunction. Features can lead to type 2 diabetes, hypertension, and cardiovascular disease. Today's disease is metabolic syndrome. Always look for metabolic syndrome, and these are the features of that. Now, what does it do? Metabolic syndrome, insulin resistance, hyperinsulinemia. First, triglycerides, increase in the SLDL, decrease in the HDL, impaired glucose tolerance, that leads to type 2 diabetes, central obesity, 200% CVD risk, hypertension, microalbuminuria, and hyperuricemia, prothrombotic state, increase in the fibrinogen, increase in the factor 7A, increase in the fibrinolytic activity. All these will lead to cardiovascular disease, metabolic syndrome. Now you see, this is also called syndrome X, also called deadly quadrant, also called Revance syndrome. You may get suddenly a short notes. Write a short notes on Revance syndrome. You may think what it is. It is nothing but metabolic syndrome. Revance syndrome. Syndrome X is there in cardiology. That's a different syndrome X. This is a metabolic syndrome, also called syndrome X. What are the factors here? Abdominal obesity, waist circumference. I repeat, men more than 90, women more than 80 is already a metabolic syndrome parameter. Triglycerides more than 150. HDL, men less than 40, women less than 50 is metabolic syndrome. Blood pressure more than 130, more than 85. Fasting blood glucose more than 110. These are the defining values for guidelines for the metabolic syndrome. Any three of these factors, we can call it as metabolic syndrome. Insulin resistance and atherosclerosis. Insulin resistance produces initially hyperinsulinemia, impaired glucose tolerance, that can lead to clinical diabetes and accelerated atherosclerosis. And that insulin resistance, not only hyperinsulinemia and impaired IGT, it also produces triglyceridemia and decreased HDL-C and essential hypertension. So insulin resistance is the common background for hyperinsulinemia, IFG, triglycerides, low HDL, and essential hypertension. So interrelation between atherosclerosis and insulin resistance. How does insulin resistance cause atherosclerosis and cardiovascular disease? Through hypertension, through obesity, through hyperinsulinemia, through diabetes, through hypertriglyceridemia, SLDL, low HDL, and hypercoagulability. All these lead to atherosclerotic vascular disease. This is acanthosis nigricans, a dark pigmentation in the flexural folds, in the axilla, in the neck, is a sign of metabolic syndrome. Acanthosis nigricans can occur due to various causes. One cause of that important cause today is acanthosis nigricans, dark pigmentation in the flexural folds. You see, the moment you see a patient neck with this sort of pigmentation there in the neck, he is a candidate that he is already having metabolic syndrome. Look for that. The creases will be there and you see the dark pigmentation. Also, knuckles are important, you see. Normally, the knuckles are slightly darker than the rest of the hand for anyone. But if the knuckles are much more darker, as seen in this picture, it is suggestive of metabolic syndrome. So neck area, axilla, and also the knuckles also you have to examine for dark pigmentation, which acanthosis is this pigmentation, nigricans is black color. Okay, composite carotid intima media thickness with metabolic syndrome in young adults. Composite ultrasound carotid intima media thickness in millimeters. Number of metabolic syndrome components. No component 0.7, one component already 0.73, two components even more, three components and all four components. So the amount of carotid intima media thickness IMT, CIMT is a measure of atherosclerotic burden, and that increases with the increasing number of metabolic syndrome parameters. Now, metabolic syndrome and 10-year CVD risk. Let's say somebody has got metabolic syndrome. What is the 10-year risk of having age-adjusted hazard ratio for cardiovascular disease? Mortality, both men and women, it is increased. Fatal CVD, also more. Non-fatal CVD is also more. Fatal plus non-fatal, compared to a normal individual of 1, is 1.6 or 1.9. It is the total risk that these people have, 10-year CVD risk. Now, we are now come to the markers. So what did we complete? We completed non-modifiable risk factors. Non-modifiable risk factors are, what are the non-modifiable risk factors? Age, gender, ethnicity, premature coronary artery disease, and then the phenotype B and personality type A personality. Then the modifiable risk factors: diabetes, hypertension, dyslipidemia, smoking, physical inactivity, abdominal obesity, and metabolism. These are the modifiable risk factors. Now we come to the makers of CHD risk. What are the makers? HSCRP, LPA, SLDL, endothelial dysfunction, ApoB/A1 ratio, and homocysteine. You must routinely measure. These are modifiable. I have treatment for HSCRP. I can treat LPA. I can treat SLDL. I can reduce the endothelial dysfunction and ApoB/A1 ratio and homocysteine. These are 6 are called the modifiable 6 or the new 6. Let us go into each one of them. Let us start with HSCRP. So you see, HSCRP and risk of future MI and CVA in apparently healthy men, quartile of HSCRP, it is in the first quartile, second quartile, third quartile, fourth quartile. First quartile is normal and fourth quartile is highly abnormal. Relative risk of MI is that much higher. Then first quarter 1, risk factor 1, risk number 1, and it is 3 times the risk. Likewise, quartile of HSCRP and stroke. The left-hand side graph is the bar chart is for MI. The next one is for stroke. More or less, it is same. Stroke and myocardial infarction are highly associated with high sensitivity CRP. What is high sensitivity CRP? There is another CRP which is called normal CRP, and that CRP tells you about the joint disease. Somebody has got rheumatoid arthritis or any other autoimmune disease, the CRP will go up. This is not that one. This is called high sensitivity CRP. You see here, Kaplan-Meier curve, survival free, low CRP, low LDL, best, white. High CRP, high LDL, red color, worst. High CRP, low LDL, that is intermediary. Low CRP, high LDL is next. That means CRP is even worse than the LDL. So low CRP, low LDL is best. High CRP, high LDL is the worst. In between the two, we have got low LDL, high CRP faring worse than high LDL and low CRP, which means that HSCRP is a higher risk than the even LDL. So now you see the CRP event-free survival probability. If CRP is less than 1, event-free probability for 8 years is around 97%, 98% of the people live without any problem. Whereas, only 95% are living with CRP of more than 3. That means the 5-year survival also is affected by higher CRP. Now, how does CRP play a direct role in atherosclerosis? What is the mechanism? How CRP plays an active role? CRP localizes in atherosclerotic but not normal intima. If the intima is normal, it will not touch it. Intima is already atheromatous, a CRP will go and sit there and do the damage. Number two, and this is induced, CRP induces production of cell adhesion molecules like VCAM1, elastin, E-selectin, MCP1, ET1, MMP1, MMP9. These are all the matrix proteases and then the cell adhesion molecules. These will increase the adhesion of the macrophages onto the cell surface, which will again absorb the LDL and form the plaque. CRP attenuates the NO protection. We know nitric oxide is protective. CRP works in the opposite direction. It removes the protection of nitric oxide. CRP increases the plasma PI1 expression. That is, it stabilizes the PI1 mRNA. And so PI1 levels are increased and that triggers the atherosclerosis. CRP triggered oxidation of LDL. So CRP increases the oxidation of LDL. Unless the LDL is oxidized, it cannot get into the intima. CRP mediated LDL uptake by the macrophages. CRP based blunting of the endothelial vasoreactivity. CRP increases the production of tissue factors in monocytes. CRP dependent monocyte recruitment into the arterial wall. CRP induced complement fixation. All these mechanisms put together, CRP is atherogenic. So you have to see that the CRP is reduced. This is a beautiful summary study. Biomarker, HSCRP, CCAM, serum amyloid alpha, interleukin 6 and interleukin 18, myeloperoxidase, SCDL40, altered thrombosis, all the factors are listed. You can see prospective studies, standardized commercial essays, additive to lipid screening, and then the additive to the Framingham risk score. Now we can see all the prospective studies are showing that all these risk factors have got a positive role to play in atherosclerosis, particularly lipoprotein, HSCRP, and then the HSCRP 4+, and then homocysteine 4+, and lipoprotein A 3+. So these are three important risk factors as we can see here. Now you see, the secret killer, there is an article in Times Magazine, surprising link between inflammation and heart attacks, cancer, Alzheimer's and other diseases. How can we fight that? This is a heart disease is an inflammatory disease. How do I test that inflammation? By a very easy new way to help predict the risk of heart attacks and stroke, a special report. What is that? Heart Association and CDC endorsed blood screen for inflammation. First added tool in 20 years, that is the HSCRP. Okay, so American Heart Association measurement of HSCRP is an independent marker of risk and may be used at the discretion of the physician as a part of global coronary risk assessment in adults without known cardiovascular disease. Weight of evidence favors use particularly among those judged at the intermediate risk. Somebody is already having a heart attack, HSCRP may not say much, but somebody is not having heart disease, measurement of HSCRP will be very useful. What is the cutoff? So normally it should be less than 1 is low risk, and 1 to 3 is moderate risk, 3 to 10 is high risk, and if it is anything more than 10, it is not the heart related CRP. It is acute phase reactant like your rheumatoid arthritis or ulcerative colitis or any other inflammatory disease can produce more than 10. So less than 1, it should be the normal value. 1 to 3 is moderate risk, 3 to 10 is high risk of cardiovascular disease. So HSCRP measurement should not be forgotten. Clinical predictive value of very low as well as very high levels of HSCRP. You see on the left side, if the HSCRP is less than 1, the risk is very low. If the HSCRP is more than 10 or 20, the risk is very high. Intermediate is moderate risk. That's why the classification low risk, moderate risk, and high risk has come based on the studies only. Now you see elevated CRP levels and obesity. Normal individuals, the CRP is less than 5. Overweight is around 10. In obese people, 20 or more. That means obesity is an inflammation. Today we know that obesity is not fat alone. Obesity is an inflammatory disease as pointed out by the HSCRP. HSCRP is specific for cardiovascular events. As you can see, quartiles, first quartile, second quartile, third quartile, fourth quartile. As the HSCRP increases, relative risk is increasing. Risk of non-cardiovascular death is very same across all quarters of HSCRP. Cardiovascular death only is influenced. Non-cardiovascular death is not affected by the HSCRP. Now, we come to the next risk factor among the markers. That is the LPA. This is also called the little a, lipoprotein small a. L is lipo, P is protein, P is written as small letter, and A within bracket small letter. So this is called lipoprotein small a or LPA. Indians are notoriously high in their lipoprotein A. Lipoprotein A cutoff value I will show you. Now you see, little a, also called lipoprotein A, similar to the LDL molecule in its structure, it has got ApoB in the protein, an additional Apo small a is attached by a disulfide bond. Primary determinant is genetic. Mainly it is not diet related. LPA is genetic, not controlled by reducing fats also. Normal value is 20 milligrams. Anything more than 30 is high risk. It competes with plasminogen because of its structural similarity, so interferes with the plasmin synthesis and thrombolytic pathway. How does it work? HSCA, LPA and plasminogen look alike in the body. When they look alike, plasminogen has to become plasmin. And this plasmin cuts the thrombosis. And it is thrombolytic pathway beneficial. Plasmin synthesis is important for our body. What happens? LPA looks like plasmin, a plasminogen. So the plasmin synthesis is inhibited. Instead, LPA is processed. It is not thrombolytic. So it increases the risk of cardiovascular disease. What is the treatment? Nicotinic acid is treatment. Available as sustained release nicotinic acid. Niacin SR is available, and it's 500 milligrams to 1000 milligrams is the dose per day. Nicotinic acid, sustained release, should not give short-acting nicotinic acid. Short-acting nicotinic acid produces flushing. Nicotinamide is nothing different. Nicotinamide is a vitamin. Nicotinic acid is an anti-LPA, and you have to use sustained release only, preferably in the night time. 500 milligrams to 1000 milligrams of niacin. Now, look. Now, let us look at various risk factors we have seen. LPA and LDL. High LDL, low HDL, high LDL. That's the standard. HDL is low, LDL is high, 1 plus. LPA is more than 30, that's also 1 plus. LPA more than 30, high LDL, 2 plus. LPA more than 30, low HDL, 3 plus. LPA excess more than 30, increased total homocysteine, 4 plus. LPA excess, increased homocysteine plus low HDL, 5 plus. That means all are additive in their risk. LPA, low HDL, high LDL, homocysteine are additive in their risk. Circulating lipids are one aspect, tissue lipid content is another aspect. Today, you measure circulating lipid, LPA, HDL, this is one aspect. What is the component of the lipoproteins in the tissues is the function now today being studied. That's about the tissue lipoproteins. Now, LDL. LDL is low density lipoprotein, and if it becomes more atherogenic by becoming a smaller dense particle, that is called SLDL. Small dense LDL, also called SLDL, which is highly heterogenic in its particle. So now you see measurement VLDL, that much size, let us say. VLDL remnant is which is much smaller because some amount of the triglyceride is removed. Intermediate density lipoprotein, some more triglyceride is removed, that is ideal. Some more triglyceride is removed, cholesterol gets concentrated, that is the LDL. And some more triglyceride you remove, cholesterol only will remain, that is called the SLDL. Okay? More triglyceride in the VLDL, least triglyceride in the SLDL. So cholesterol lipoproteins, triglyceride lipoprotein. VLDL are ideal of the TG rich lipoprotein. Apoprotein B, non-HDL-C, cholesterol-rich lipoproteins are LDL and SLDL. SLDL is the smallest particle other than HDL. HDL is the smallest particle, but it is a protective particle. Among the atherogenic particles, SLDL is the very dense lipoprotein, small lipoprotein. Significance of SLDL. Low cholesterol content of the LDL particle increases the number given to the LDL-C, associated with increased levels of TG, LDL-C, and HDL. Marker of common genetic trait associated with coronary artery disease, which is called subclass pattern B. Possible mechanisms of increasing atherogenicity: greater arterial uptake by the macrophages increases the oxidation susceptibility. These are the three mechanisms by which it acts. Now, LDL pattern at A and B. A is LDL, B is SLDL. So, number of cases you see and controls, the odds ratio is 3 times compared to the LDL. That means SLDL is more dangerous than the LDL itself. Now, we are not routinely measuring. What you have to do? HSCRP you have to measure, LPA and SLDL you have to ask. And if SLDL is more significant. SLDL tells that the heterogeneity propensity is more. Endothelial dysfunction. What is endothelial dysfunction? We will see now. Now, hypertension, diabetes, smoking, LDL, homocysteine, estrogen deficiency, either surgically or naturally. So, if woman becomes surgically estrogen negative by hysterectomy or naturally menopause also. Hypertension, diabetes, smoking, LDL, homocysteine, estrogen deficiency, all of these, they increase the oxygen at the level of the endothelial cell. This oxygen, what it will do? It will oxidize the free radicals and H2O2 is formed. That is, that H2O2 is a peroxide. Okay, dihydrogen peroxide, and that peroxide, it acts on the vascular smooth muscle that causes the endothelial dysfunction. Okay. How is that H2O2 mitigated? H2O2 is absorbed by the NO, nitric oxide. So much so any free radicals, free oxygen, and H2O2 and free oxygen is there. It is taken away by the NO, and then it is the risk is reduced. Supposing the excess of these free radicals are there, O2 and H2O2, that results in the nitric oxide is not sufficient to neutralize the free radicals. That causes endothelial dysfunction. Endothelium is the largest endocrine gland of the body. Apoptosis occurs, leukocytes start adhering, lipids get deposited, vasoconstriction occurs, and then there will be vascular smooth muscle growth and thrombosis. All of them are pro-atherogenic in nature. Now, see this beautiful study. Prediction future CVE event by endothelial dysfunction. So there were already around 10 studies. 0 is no risk, that is the normal risk. Relative risk of minus is better. Relative risk of plus is worse. +2, +4, +6, +8. Increasing relative risk with endothelial dysfunction. Every study has shown that increasing endothelial dysfunction increases the risk of cardiovascular event. And some studies have even said 6 times or 5 times, something like that. No study has reported endothelial dysfunction is not a factor. Endothelial dysfunction is a very important factor for cardiovascular events. So what is the treatment? Supposing all this I know, can I treat endothelial dysfunction? How can I treat? How can I make my endothelium healthy? Endothelial health is very important. Control all the CV risk factors. Main focus on the big 6: diabetes, hypertension, lipids, obesity, smoking, sedentary lifestyle. If you control these things, the endothelial dysfunction can be controlled. Diet and physical activity are important in the treatment of ED. Statins are the first line treatment of ED. If you detect endothelial dysfunction, you have to put the patient on statin. Glitazones are also having a proven value on the endothelial dysfunction. Insulin and treatment for insulin resistance improves the endothelial dysfunction. In one word, control the major risk factors. Think of statin, think of glutathione, control the insulin resistance. Endothelial dysfunction can be controlled. Now we finished HSCRP, we finished ALPA, we finished SLDL. We also understood endothelial dysfunction to be treated. How do I treat ALPA? With niacin. How do I treat SLDL? SLDL directly is not amenable. If you control the levels of LDL, the conversion to SLDL will be reduced. Statins come very handy. HSCRP, again, HSCRP is a high risk because of the obesity. If you control obesity and smoking, HSCRP will come down. And then endothelial dysfunction, we have already seen what is the treatment. All the risk factors together will cause the endothelial dysfunction. Then there's one thing called the ApoB by ApoA1 ratio. B is a bad protein, A1 is a good apoprotein. If B is more and A1 is less, the ratio will be more than 1. ApoB by ApoA1 ratio, more than 1 says that bad proteins ApoBs are more compared to apoprotein A1. Normally, ApoA1 should be more than the ApoB. That means the ratio should be less than 1. If the ratio is more than 1, it is atherogenic. How do I go about that? You can see ApoB by ApoA1 ratio. As you see from 1, ApoB by ApoA1 ratio of 1 to 10, as you go on increasing, the risk is increasing. In fact, very much, this is called the Interheart study by Yusuf et al. From McMaster University, where I studied. This gentleman published a landmark study, Yusuf et al., in the Interheart study, that has documented very clearly that ApoB by ApoA1 is a very important parameter. So you have to assess that. Another risk factor is homocysteine. Normally you don't measure the homocysteine. There are two things, homocysteine and homocysteine. Cysteine we are not interested, homocysteine only we are interested. And what you measure is total homocysteine, which will measure both, and we are interested in the homocysteine. Normal value 10 micromoles per liter. Okay, how do I folic acid, vitamin B6 and B12 are essential for normal transsulfuration and remethylation cycles. So for the normal transsulfuration and remethylation to take place, we should have adequate quantities of folic acid, B6 and B12. Excess homocysteine generates oxidative stress on the cell membrane. DNA and protein denaturation occurs due to ROS formation. How do I treat homocysteine? Folic acid 5 milligrams per day plus vitamin B6 and B12 are to be given on regular basis. If you find somebody whose homocysteine is more than 10 micrograms per millimoles, micromoles per liter, you have to put them on folic acid plus vitamin B6 and B12. Now, homocysteine levels, normal 0 to 5 is normal, 11 to 30 moderately elevated, 31 to 100 intermediate, severe more than 100. So, we have finished all the risk factors which we said are the markers like HSCRP and then the LPA, SLDL, endothelial dysfunction, ApoB by A1 and homocysteine. Now we are left with the CHD risk markers, which are very important. The simple 6, which we rarely try to do. CH risk factors, which are markers. The simple 6, waist circumference. We have to measure the waist circumference. Cutoff value 90 centimeters or 36 inches for men, 32 inches or 80 centimeters for women. Erectile dysfunction must be questioned. Every cardiometabolic suspect patients, we have to ask privately whether they have erectile dysfunction. Erectile dysfunction is endothelial dysfunction. And erectile dysfunction is one manifestation of endothelial dysfunction. Today, in men, we see a lot of them have erectile dysfunction and they don't expose very easily unless you probe them and ask them. Ankle brachial index is very important. Intermittent claudication and pedal pulse should be palpated in all the patients. Pulse pressure is also important. Importance of the isolated systolic hypertension. MEAU, microalbuminuria, is a very important risk factor, a prognostic index also. And LVH by echocardiography, ECG and CXR, preferably by echocardiography. So every patient of cardiometabolic disease, waist circumference, questioning for endothelial erectile dysfunction, and in women, lack of libido, and then PCOD is equivalent to erectile dysfunction in women, ABI, ankle brachial index, and intermittent claudication, and weak pedal pulses, increase in the pulse pressure, isolated systolic hypertension. Microalbuminuria must be measured as a prognostic index, and LVH must be documented with echocardiography in all cases of cardiometabolic risk. Okay, now each one we have to think. Okay, waist circumference. Again, we have seen this is how you have to measure, where you have to measure, not around the umbilicus, because with abdominal obesity, umbilicus will be shifted down. So don't try to measure there. You have to take the iliac crest and the lower border of the rib. In between the lower border of the ribs and the iliac crest, you have to keep. Tape should be horizontal to the ground. You should not keep the tape in a like this. It should be horizontally placed, and that is how you have to measure. It measures intra-abdominal fat. Subcutaneous fat is not dangerous. Intra-abdominal fat is dangerous. Intra-abdominal fat is called bad fat. Bad fat and bad fat. White adipose tissue, brown adipose tissue. Brown adipose tissue is favorable. White adipose tissue is intra-abdominal fat, bad fat, and that is going to be dangerous. How do I know that? Don't have to do MRI or anything. Just take the waist circumference. What is the cutoff value? Less than 90 for men, less than 80 for women. So you see BMI less than 23, waist circumference also is normal. That is good. BMI is more, but waist is normal. Bad. BMI is normal, but waist is very high. Worst. Both of them are increased. The BMI is increased, waist is increased. That means waist is more important than the weight. Having said that, controlling the weight also is important. This is called the treasure in the tummy. Every one of us have got this abdominal obesity.
I think waist circumference more than 1 or 2, and
waist circumference of more than waist circumference less than 90, BMI less than 23, normal. That is risk one. When the waist circumference has gone up, let us say more than 90, but the BMI is still normal, it is 8 times the risk. But waist circumference normal, BMI is increased, somewhat okay. But worst thing is the waist. Both are raised, that is waist is increasing, BMI is more, risk is 60. To say that waist is more important than the weight. Okay. Now, erectile dysfunction. ED is equal to ED. There is a paper by me, ED is equal to ED, published. And this penis is the barometer of the endothelial health. Penis is the barometer of endothelial health. Erectile dysfunction is a mirror of cardiovascular risk. What is the equivalent in women? Loss of libido and PCOD is the equivalent in women for the endothelial dysfunction. Okay, ED is equal to ED. Erectile dysfunction is equal to endothelial dysfunction. Marker of CV health and CVD, very rarely questioned by physicians. Unless the patient comes and tells erectile dysfunction, don't rub it away as give some tablets for them, Viagra, something like that, and brush it. Endothelial dysfunction should be addressed. If somebody complains, investigate for metabolic syndrome, cardiometabolic risk. If they do not complain, you elicit whether they have any problem. Due to poor nitric oxide balance, endothelium. What is after all erectile dysfunction? Lack of vasodilatation. Erection, penile erection, is a very profound vasodilatation and engorgement of all the penile capillaries in the corpora cavernosa. So when the capillaries are not dilating, the same thing is happening in the heart also, in the other blood vessels also. It's a problem of vascular vasodilatation is at fault. Penis is the barometer of vascular health. Close questioning is essential to uncover it. Data suggests that it is more in South Asians. That means India, Burma, and then Sri Lanka, Southeast Asians and all that. Erectile dysfunction is a very important aspect. Ankle brachial index, very rarely measured by all of you. You have to measure the ankle blood pressure and the brachial blood pressure. I have shown you in PAD class, I have shown you normal ABA is 1 to 0.9, ABA less than 0.9, 95% specific for angiography, ABA 0.6 to 0.84 correlates with claudication, ABA less than 0.6, advanced limb ischemia. What is ABI? Ankle brachial index. That means ankle blood pressure is much lower than the brachial blood pressure. That means the vessels to the lower limb are having atherosclerosis and not able to circulate properly in the lower limb. That is measured by the ABI. Anything less than 9 is important. Less than 6 is advanced limb ischemia. Always check pedal pulses. If you do not touch the feet of the patient for pedal pulses, God will not give you blessings. You have to touch the foot to examine for the pedal pulse. Question for intermittent claudication. You know what is intermittent? ABA and population sensitivity. Coronary artery disease, sensitivity and specificity. Stroke, sensitivity and specificity. All-cause mortality, sensitivity and specificity. CV mortality, sensitivity and specificity. What does that mean? ABA is not a useful tool to negate the disease. ABA is very useful to confirm the disease because of the high specificity. Now, Edinburgh artery study on the ABI, you can see more than 1.1, 1.1, 0.91, 0.71, less than 0.7. As the ABI is decreasing, the risk is increasing in all these people. A 5-year follow-up study showed that the ABI of less than 0.7, the risk is 3.8 times. Now you come for the pulse pressure. Importance of isolated systolic hypertension. Isolated systolic hypertension, as you see, more than 170, 150, the diastolic blood pressure being normal, the systolic is still higher, pulse pressure is higher, so 2.8 times compared to diastolic blood pressure alone, systolic blood pressure more than 170 has got a very high risk. Birmingham study at all levels of systolic blood pressure, diastolic blood pressure is inversely related to CV risk. Consequently, pulse pressure emerged as the best predictor of CHD risk in older subjects. Greater reliance should be placed on pulse pressure. Then pulse wave analysis. We have a small meter, just like your oximeter. We can now implantation tonometry, infrared sensor, digital volume pulse, that's called the DVP. You can analyze the pulse wave and see whether it's atherosclerotic. This one, there is a machine like that, just like your BP apparatus, it will be there. You can see, measure the pulse metric there. Brachial artery distensibility, you can measure using the oscillometric BP cuff, which measures the brachial artery distensibility. Okay. Now, finally, microalbuminuria is a prognostic index. Microalbuminuria 3 to 300, 30 to 300. Albumin in the urine in 24 hours. Normal is less than 30. Macroproteinuria is more than 300. Less than 30 milligrams is normal. More than 300 is macroproteinuria. In between is the microproteinuria, detected by a dipstick test. We have got microalbuminuria dipsticks now. Accurate assessment for 24-hour collection. ACR spot urine you can do. MAU is a marker of early stage of renal damage, and regression of MAU decreases the risk. Prognostic marker also. A marker for generalized CV. None of you are measuring MAU, microalbuminuria. All of you please measure the microalbuminuria without any doubt. Normally is less than 30 and less than 20 timed collection, spot collection, less than 30, microalbuminuria 30 to 299, clinical macroalbuminuria more than 300. Because of variability in urine albumin excretion, always should be considered 3 to 6 times should be abnormal before considering the diagnostic threshold. False positives can occur after exercise, fever, heart failure, marked hyperglycemia, hypertension, pyuria, and hematuria. So if you have these conditions, don't rely on MAU, like, post-exercise, fever, CHF, hyperglycemia, severe hypertension, hematuria, pyuria. Otherwise, less than 30, normal, 30 to 300, abnormal, more than 300, macroprotein. Relative importance of microalbuminuria is, see, microalbuminuria, the odds ratio is 10 times compared to cholesterol, which is 2 times. You are always preoccupied with cholesterol. Cholesterol is important, no doubt. Cholesterol is 2 times, hypertension 3.2, smoking 6.5, microalbuminuria 10.02 is the odds relative risk and odds ratio. Very important for us to measure. Finally, for today, we have got the echocardiography, ECG, and X-ray. LVH must be measured. This is normal left ventricular thickness is 10 millimeters, less than 10 millimeters. LV thickness in the echo report should be less than 10 millimeters. In this case, left ventricle is so much thickened that the size of the left ventricular muscle is 26 millimeters. So you have got the scale on the other side to show how much it is more than 10 millimeters. 10 millimeters or 1 centimeter is normal. But anything more than 10 is abnormal. This particular case, it is 26. Left ventricular hypertrophy. This is a transverse section of the heart showing the left ventricular muscle on the left side. Right side is the right ventricular wall. Okay. Left ventricular hypertrophy is the single most important predictor of cardiovascular disease. So Framingham Heart Study has shown that, whoever has got LVH, the risk is much higher. That is 69 versus 23, 655 versus 15. That is for the CHD. For the stroke, 10 versus 32, 8 versus 42. All these things point to us that this one, left ventricular hypertrophy, is a very strong risk factor for coronary artery disease and stroke. What I have to do? I must measure every patient, echocardiographic evaluation for left ventricular hypertrophy. Now, we are now going to look at the markers in the next class: dippers, non-dippers, brachial flow mediated dilatation, PCOD, carotid intermediate thickness, fluorescence fundus angiography, stress thallium scan. We will try to cover, and also treatment aspect in the subsequent class. Now, today we have completed 3 levels. We have completed the simple 6-way circumference, erectile dysfunction, and also the ankle brachial index, pulse pressure, microalbuminuria, echocardiography, and LVH we have completed. Beyond that, we also looked at the other parameters, like, most importantly, the HSCRP, LPA, SLDL, endothelial dysfunction, ApoB by A1, and then homocysteine. All these things also we have looked at. So let us look at these things in the next class about the other aspects of cardiometabolic risk. Okay, with this we'll stop here. It's nearing 4:05.